Hi, our dear attendees. Now, once more, we are together in one of the ASPA FLEX webinar series, like we had been doing for the last 2 years. In this webinar, we will be discussing about perioperative care in pediatric cancer patients. As you know, these children has to undergo lots of series of operations and the therapies under anesthesia, and they are very fragile. So we will be dealing with our cancer pediatric patients. Today, our program is with our precious speakers from Turkey, France, and India. Canan Bor, Lucas Opitz, and Dr. Jason, our doctor. The program will be led by me. I'm Serpil Ustalar Özgen from Acıbadem University in Istanbul, Turkey. I'm very happy to lead this webinar since we have very precious speakers here. The program consists of we will begin with Dr. Canan, and she will be speaking about perioperative management of an infant with neuroblastoma. And Dr. Lucas Opitz will be speaking about iterative anesthesia, which is a new term in pediatric anesthesia, iterative anesthesia in radiation therapy centers. And Dr. Jason doctor will be speaking about the post-operative management of children after major tumor surgery, tumor excision surgeries. We will have a question answers and discussion part at the end of this all talks, and then we will finish about 6:20 by Singapore time. Now I'm working at, as I said, in Istanbul, and my interests are in pediatric anesthesia, as you know, and we have moderators from Korea and from India, from Cambodia, sorry. Professor Dr. Hee-Soo Kim is from Korea, and she is working at Seoul National University Hospital, and her interests are in pediatric anesthesia, machine learning of medical data, and medical devices. And we have Dr. Nung Phik Tae as the co-moderator. He is a consultant anesthesiologist and working in the National Pediatric Hospital in Cambodia, and he is a member of Comachun Society of Anesthesia and Critical Care Medicine. He is interested in neonatal anesthesia, and he does pediatric cardiac anesthesia and neuroanesthesia. And before I give the word to Dr. Hee-Soo Kim, I want to remind you some of our housekeeping rules. You can ask questions during the webinar, but we will discuss them lively at the end of the all webinar. But during the webinar, you can ask the questions in the questions and answers section, write them, and during the discussions, we will reply them. Chat and raise hand functions are disabled. Please do not use them. Our moderators will highlight your questions at the end of the speech. Regarding the certificate of attendance, they will be sent automatically, generated and forwarded to the ones who submitted the post-webinar survey, which will be sent to your email addresses. Post-webinar survey will be forwarded tomorrow at 5 Singapore time through email. Please ensure that you have correctly keyed in your full name and emails so that the certificate of attendance are sent correctly. Please, these webinars are all recorded and they will be online at the Asian Society of Pediatric Anesthesiologists website, at Facebook and YouTube. Please visit, like, and follow us. And you can find there all previous webinars as well. And during our lectures, there will be polling questions. When a poll is launched, you will be prompted to answer the questions. You will have 30 seconds to respond and submit your answers. We will share the results soon after we end the poll. After the results is shared, you may close the poll so that you can see the slides shared by our speakers. And I give the word to Professor Dr. Hee-Soo Kim. Hi.
Hi, thank you for your introduction. I'd like to introduce the first speaker, Dr. Cannonball. Her lecture is Perioperative Management of an Infant with Neuroblastoma. I'd like to introduce her once again. She is anesthesiologist, associate professor in Ege University School of Medicine. She is working in many societies, and she has several positions. ASPA Part, TYBD, ERC, GKDA. And her interests are pediatric anesthesia, intensive care, CPR, ophthalmic anesthesia, and safety C. Okay, Dr. Cannonball, please.
Hi. First of all, I would like to thank the organizing committee giving me this opportunity, because really it's great pleasure to be here. Today we are going to talk about neuroblastoma and anesthesia. And I don't have any conflict of interest about this talk. Let's start with the case. And as you see, a cute girl, she is 24 months of age, and she admitted to hospital with abdominal pain and vomiting. And in the imaging, we have seen large diameter of tumor. She had just mild anemia, and catecholamine level were high, and also metabolites were high. And we planned open surgery. And which drug shouldn't we use for premedication? A, midazolam, B, ketamine, C, dexmedetomidine, D, propofol, E, clonidine. Let's see your answer. Okay, we got the answer, and we shouldn't use ketamine because already. Ketamine makes sympathetic stimulation, and she had already high catecholamine levels. And she will have such a big surgery. As you see, she has big tumor, and we will take it out, and also she will get a very big incision, large incision. And what is your anesthetic plan for her? A, general anesthesia with volatile anesthetics. B, regional anesthesia plus general anesthesia. C, TIVA. D, regional anesthesia plus TIVA. Okay. Okay, we will see the answer at the end of this talk. Today, in this talk, we are going to discuss about neuroblastoma and surgery, and anesthesia and cancer relation, and perioperative management, and fluid and blood management too. As you see, in childhood time, we can see many tumors, but the most common is neuroblastoma. After that, lymph tumor comes. And a neuroblastoma is an embryonal tumor, we know, and it originates from sympathetic nervous system and derives from neural crest located any place to synthesize catecholamine. And we can see in newborn infants and children too, mostly they are under 4 years old. And on the diagram, you can see at the diagnosis, nearly half of them under 1 year old. And incidence is high, and we can say 10% in pediatric tumors. and most common extracranial solid tumor in childhood. Unfortunately, she has metastasis at the diagnosis time, nearly 75%, and regional metastasis to lymph nodes, but distant metastasis to bone marrow, bone, liver, orbit, or skin. And mortality is nearly 15%, we can say. Prognosis is changes because patients depends on patient stage, age, and diseases of histology and biology. And literature says sometimes spontaneous regressions without treatment, but mostly aggressive and disseminated disease. Of course, gold standard is induction chemotherapy and then surgery treatment. And locate any place, as I said, in sympathetic, along the sympathetic chain. We can see on cervical, thoracic, intra-abdominal, retroperitoneal, or pelvic. And what kind of problem makes us in the operating room? It makes us, for example, on the cervical, can compress airway and trachea. Sometimes we can see Horner syndrome too. On thoracic, we can see compression of vena cava or aorta, and we can see respiratory distress, pulmonary atelectasis. Intra-abdominally, sometimes it's very huge amount, big mass, so can increase the intra-abdominal pressure that makes us risk of aspiration and pulmonary atelectasis. In the retroperitoneally, and secrete the catecholamine and makes hypertension and sometimes heart failure too. Luckily, we don't see much pelvic location, but literature says can make cord compression, paraplegia, and paraparesis. As you see on the cervical, have a close relation to big vein, arteria, and nerves. That big mass and makes compression to airway too. So before the operation, we always check the image. On the cervicothoracic neuroblastoma, as you see, extends skull basis to posterior mediastinum, and also risk of causing damage to big vessels, arterias, and phrenic nerve, sometimes laryngeal nerve, brachial plexus, and needs such a different incision. On thoracic neuroblastoma, also, it originates from thoracic sympathetic ganglion chain, mostly is posterior mediastinum, and it has a better outcome compared to abdominal neuroblastomas. We can perform the operation open thoracotomy and or sometimes thoracoscopy. And abdominal neuroblastoma, mainly location is adrenal glands, so needs adrenalectomy and mostly unilateral adrenalectomy. We can perform the operation at open, laparoscopic, or robotic assisted also. But sometimes tumor is very huge, can compress, as you see. Before the operation, we should check where it compresses. Pelvic location, as I said, we don't see much, but if we see, it is challenging for surgeon and also anesthetist also. And you can see the location sometimes compresses spine, and neurosurgeon also admit operation. And image-defined risk factors is a score system. And you see it's a huge tumor, sometimes compresses big vein, arteria, and other organs. And before the operation, we should shrink the tumor. So compression get back, then the surgeon can operate the patient. And surgery, I said, can be open, laparoscopic, robotic, or video assisted. And what is the role of anesthesia in neuroblastoma? You saw all the stages on the slides. For the imaging, chemotherapy, and radiotherapy, we give sedations. And for the biopsy and resection of tumor, we give general anesthesia. Sometimes for the procedure, invasive procedure, we give anesthesia also. For pain control and intensive palliative care, also we take care of. So every steps. We should communicate and plan with the multidisciplinary team and explain to patients and family and always discuss with them. Preoperative evaluation is important for the anesthesiologist. Sure, we should get full history. Did she get any chemo? Did she get any radiotherapy, surgery, or immunotherapy? And we should examine the patient, take the vitals, EKG. If she get chemo and especially doxorubicin, does she have any symptoms about cardiomyopathy? And sometimes hypertension we can see, we don't see much, nearly 10 to 19%. But if she has, always check the drugs. How long did she get antihypertensive? Always we should check whole blood count and all the laboratory and check the imaging also. For the premedication, we can use midazolam, clonidine, dexmedetomidine. If the patient has IV access, we are very happy. We use propofol. While parents are hugging their child, we keep them asleep in their lap. Then we take the patient from them. Mostly we use midazolam perorally, and sometimes we use dexmedetomidine if the child refuses taking perorally midazolam. We give intranasal dexmedetomidine. We use 3 microgram per kilogram, and we get really good results. But we are happy with the propofol also if she has IV access. Intraoperatively, if it's just biopsy, we give standard monitoring. But if the tumor, we are planning to resection whole tumor, always we insert radial artery, give invasive monitoring, central venous catheter, and you can use literature says pulse pressure variation and stroke volume variations. And we always insert nasogastric tube. And sure, we want to see urinary, we want to see urine output, and always keep the temperature. We keep the patient from hypotherapy. So insert the temperature probe in esophageal. And in the induction, if the patient has IV access, you can use propofol. But if they doesn't have, so you can use volatile anesthetics. And after IV line, give enough amount of opioids and neuromuscular blockers and lidocaine to suppress sympathetic response. And after that, intubate patient. If it's thoracic surgery, you can use one leg ventilation. And for that, also discuss with your surgeon. In the intraoperatively, we don't see much hypertension. Rarely, very rarely, 3 to 3% literature also says. And mostly we can see while the surgeon manipulates the tumor. And that time we might see hypertension. Mostly we see tachyarrhythmias. And preoperatively, most patient takes alpha blockers. So when they come to operating room, their hypertension is regulated. And in Turkey, we have prazosin and doxazocin. If we need phenoxybenzamine, we should take it from other countries, but we can use prazosin and doxazocin mostly. In the operating time, in the operating room, if we get any intraoperative hypertension, what can we use? We can use remifentanil, esmoprazole, dexmedetomidine, and also magnesium sulfate. But also literature says phentolamine, sodium nitroprusside, glyceryl nitrates, labetalol too. Mostly we take control with remifentanil. We sometimes rise up the level amount till 3 microgram kilogram per minute, and we take control the hypertension. But rarely we use esmolol too. What is the critical part of resection after tumor ligation? Because when the surgeon ligate the tumor, then suddenly hypertension might become. And that time we need fluid resuscitation. Even we give fluid, Sometimes we need norepinephrine or epinephrine infusion too. And with the fluid management, how we manage? First of all, we follow 2022 fasting guidelines. So 6 hours for solid, 4 hours for formula, and 3 hours for breast milk, 1 hour for clear fluid. So patients don't come to operating room with dehydration. And in the operating time, we always calculate fluid restoration case-to-case basis. And for the maintenance fluid, we give balanced solution with 1 or 2% dextrose in it, and always check the blood glucose and in perioperatively. And if we need replacement therapy, we use balanced crystalloid solution too, and mostly plasmolide or ringer lactate. And the purpose of fluid management, keep the patient evolving and maintain adequate tissue perfusion and oxygenation, and avoid hemodilation, definitely avoid hemodilation. And sometimes we give volume therapy too. And that time we need 5% albumin, and sometimes we use hydroxyethyl starch also. We don't use gelatin too much because of anaphylaxis. Sometimes we need transfusion, blood transfusion too, but we don't want to give blood transfusion because we all know blood transfusion makes transfusion-related immunosuppression, and that makes infection, cancer recurrence, and increase the cancer-related mortality. That's why we always approach as a multidisciplinary team. And oncologists, when they saw the patient before the operation, they optimized hematopoiesis if patient needs give iron, folate, or B12. And in the surgery, we also, as anesthetists or also surgery, minimize blood loss and bleeding, and always optimize physiological tolerance of anemia. And if the patient is bleeding, we check the hemoglobin and hematocrit level, and always calculate minimum allowable blood loss for every patient. If the patient is bleeding, if you have for the blood products, you can check viscoelastic assays and then give what she needs. And our approach should be restrictive hemoglobin approach. So for infant and children, we accept 7 grams per deciliter. And in the beginning of surgery, we give antifibrinolytics. We usually use tranexamic acid, 15 milligrams per kilogram, and always keep the patient from hypothermia. It's the really big problem in the operating room. And as blood transfusion, anesthesia and surgery also itself immunosuppressive. And we know post-operative pain, hypoxia, hypothermia inhibit natural killer cell activity. And some volatile agents like isoflurane, sevoflurane also. And many studies says opioids has inhibition of natural killer cell activity. But on the contrary, and some of the agents promote natural killer cell activity, like desflurane, beta blockers, propofol, local anesthetics, cyclooxygenase inhibitors. And you can see on diagram, opioids and volatile anesthetics suppress the immunity and increase the tumor growth, metastasis, and angiogenesis. And propofol anesthetics, propofol and local anesthetics has a negative effect on metastasis, tumor growth, and angiogenesis, and increase the immunity, natural killer cell activity. And you can see many literature on the PubMed and on the internet, and lately also comes some of the literature, but most of them are retrospective, and they are studied on adults and all the colorectals, breast, ovarian cancer, and melanoma, some others. None of them are neuroblastomas. And but some studies says propofol and volatile anesthetics. There's propofol and compared to volatile anesthetics, TIVA has potential beneficial effects, and one of them says it has positive effects. But we don't know yet the anesthesia is a friend or foe. Some of the agents are close to friend, some of the agents are close to foe, enemy. And we can say yet, because many of the studies are in different cancer types. They have used different opioids. They use different anesthesia type. Some of them used regional anesthesia, some of them they didn't. And some of the patients got blood transfusion, some of them didn't. And they had different drug doses, different patient temperature, physiological stress, and we can't say the exact decision. That's why current evidence does not justify any change in clinical practice. Just suppress stress and pain responses as much as you can say, we can say. And with the neuroblastoma, lately study came from Singapore, and they compared the general anesthesia plus general and epidural anesthesia in neuroblastoma patients. And they looked for relapse-free survival, but they couldn't find any significant data. So we can't say just perform epidural or regional anesthesia, but we can say suppress the stress response and make very good analgesia. That's why you can use epidural or some of the plugs. And in my center, we usually use transverse abdominal plane block and aerator spine plane. And we are very happy with it. And if you can do also. At the end of this talk, I can just suggest that and do very carefully preoperative evaluation. And if it's a big surgery, use invasive monitoring. Then you will see how safe you are. And if you have opportunity, you can use TIVA, use regional anesthesia, and use minimum opioids if you can. And always follow restrictive transfusion protocol and use effective analgesia. Whatever you do, yes, just do effective analgesia. And thank you for listening to me. This is my city, Izmir, in Turkey, and we would like to have you in here.
Okay, thank you. Thank you for your nice lecture.
Yes, thanks to Dr. Kanan. The next, I would like to invite Dr. Lucas Opitz to talk about iterative anesthesia in radiation therapy center. Dr. Lucas is a head of Pediatric Anesthesia in Radiation and Proton Therapy Center of Anton Lukasik Oncological Hospital in France. He is a senior neonatologist in NICU University Hospital in Nice, and also a consultation for perinatology projects and pediatric anesthesia and intensive care in different regions of Eastern Europe. His interest in ethics in perinatology, promotion of free access to effective health service for every child around the world, and also his interest in simulation also. So now please enjoy with Dr. Lucas.
My dear fellow pediatric anesthesiologists from Asia, from this huge continent with so many different realities, so many cultures, so many people. and I'm sure so many different anesthesiological standards. I was very flattered when I was asked to participate at this webinar. Flattered because I think that our exchanges might be very, very fruitful and very interesting. I was talking about standards and saying about the different standards we have in our different realities. And one might think that in Europe, standards are quite homogeneous. This is actually not quite true, because as I could experience when I was asked to build up a pediatric anesthesiological unit in a radiation center in the southeast of France, in Nice, for the proton therapy. I first looked around me, and so I tried to find out what were the standards of other centers. And I realized that, well, everybody actually tried to do the best he could or she could in quite difficult circumstances. And so I saw that there was no real unity and no clear guidance of how radiation centers should be implemented. And this is what I want to share with you. And but before sharing this, I want to point out that I have no conflict of interest. And I want you to understand that you might ask for some recipes for how to implement anesthesia or sedation in radiation centers, but I will not give you these recipes, because I will just ask questions. So you will have more questions even, which might be a basis for us to discuss later. So first of all, I wanted to show you this boy who is 5 years old. He's quite an already a grown boy, and he could have this radiation treatments without anesthesia or sedation, but he had quite a difficult clinical moments, and therefore we had to take care of him and to do some sedation or general anesthesia. Usually our children are rather well, between 2 and 3. This is the standard child we would put asleep or for radiation treatments. But sometimes it goes up until 5 or even more if they are not stable, or if their psychology does not allow us to have the treatments without them moving. This is the main issue. These children should not move, because if you move of a small little slight tenth of millimeter already, the treatment might be not efficient or dangerous. So we have this 5-year-old boy. He's 20 kilos. His weight is 20 kilos, and he had in a quite dramatic way, as always for neurosurgery, surgery for anaplastic and ependymoma, which was grade 3 of the posterior cranal fossa. And the post-operative period was very difficult, with long-lasting stay in PICU, with brainstem edema, and with hypertension, intracranial hypertension, leading ventricular peritoneal shunt, difficult weaning from a ventilator with a palsy of right vocal cords, swallowing difficulties, and therefore aspiration system. All this in a context of a child that had kind of coma. But according to the SIOP, which is the International Society of Pediatric Oncologists, the radiation treatment should start at the latest for 42 days after surgery in order to be as effective as possible. But this child was in the PICU, and it was very difficult to take to treat him within this frame. So we had to do the dosimetric CT scan. We tried to do it as early as possible. And that was in mid-August 21. The history started in June 21. And when we received the child, because you must understand that between the CT scan and the actual treatment, there are at least 10 to 14 days lapse of time, because the radiation oncologist has to do all his calculations and has to do the radiation program. And this takes quite a long time. So we received him at mid-August, and he was in spontaneous ventilation. He was extubated, but he had a high flow oxygen cannulas with 40 liters a minute. He had lung crepitations, and his lung was definitely not a good shape. It was a pneumonia, a nosocomial pneumonia due to the aspiration syndrome. He was a kind of slight locked-in syndrome. So he reacted to the environment, but not in an adequate way, and he had spontaneous movements that made him being unable to stay calm and immobile during radiation treatment. He had also had a gastric tube and a PICC line. So what would be the anesthesiological tactic in this case? Here you can see the radiation treatment plan that would be a target volume of 54 gray. That would be split into 30 sessions. That means that this child, as many children that we treat, would have repeated iterative anesthesia every day for 6 weeks, or sometimes even more. In this case, chemotherapy was given after the treatment, but in other tumors like rhabdomyosarcoma, we would do chemotherapy in the same period as the radiation therapy. So that makes it even more complicated. So this is what it looks like. You see our proton therapy center with our machines and the treatment. And I want to ask you if you know the 10 anesthesiological commandments. It's kind of a joke, of course, but we all in anesthesia know that we have to keep our airways open of our patients and to allow the oxygen and CO2 exchange. We need normally always a venous access. We have to monitor the patient, we have to keep a record, and we have to be ready for any event that might happen, and to intervene fast and to be prepared to this, to be timely. We have to impose an adapted fasting to our patient. That is very important. But in an oncological situation, the nutritional aspects are very important as well. So we have to take a balance out of this. We have to avoid all iatrogenic complication, toxicity, nosocomial infections, or discomfort. But that's what we do in the normal surgery, to not to accept clinically unstable patients. We have to evaluate the risk, and we should be time efficient. Also, our authorities should give us all the means, all the infrastructures for doing this in a safe way. But if we have anesthesia every day for 6 weeks, that means that we have also to prioritize the child and the parents' well-being, because a child with a big stress undergoing radiation therapy every day for 6 weeks, that is quite a big challenge, psychologically spoken. So we have to understand what are the issues in iterative radiation anesthesiology. What are the radiation oncologist musts? And I was talking about the fact that the children should not move, not even the slightest millimeter. What are the risks? What should be anticipated? What are the adverse effects, accumulating effects, iatrogenic, nosocomial? What will be the comfort of life during this period? So is there a best technique? And what should we do with very young children? Because sometimes we start from 1 year on, but sometimes we have even smaller children. It's rare, but it can happen. And so we have to understand if this conforms to the 10 commandments. The 10 commandments, with all what we have, all these different issues, as you can see here, makes it very, very complicated. And so we can say that the iterative anesthesia for children in radiation centers is a real challenge, and we can ask ourselves, are we outlaws? So here we have this little Pinocchio, I don't know if you know him, who wanted to save the world, but the judge says that he has to go to prison. So we have kind of always this kind of thinking of, well, maybe there might be some legal issues or some medical legal issues, which, well, we know in America is extremely frequent. In Europe, I don't know, it's kind of intermediate. I don't know about you in Asia, in your different realities. So if we want to look at the things individually, what can we do to keep the airways open. No device, laryngeal mask, or an endotracheal intubation that would be every day. Imagine how invasive this is. Venous access, we know that central venous access is prone to complications. And we have chubby small children that are difficult to where peripheral venous access is difficult, and especially during 6 weeks. So we have to discuss this. Remember that central venous access always exposes to iatrogenic risks that might be up to 25%. So we have to stay close to the patient. But how can we stay close to the patient if we are separated from this patient by a big wall and a serpentine that goes to the treatment room, where this big wall of full of concrete and lead? So this is, again, we need a remote control. We need good infrastructures and devices. We have to stay close. Well, again, we cannot stay close. So we need things being far away, and we need a remote control for that. So we need the classical monitoring, and the more monitoring we have, the more we can anticipate if there was any problem. So if there's any problem, we are in a remote place. PICO is far away. There's no other pediatric anesthesiologists around us. We are all alone, and we have to deal with this. We are surrounded with people who are good professionals maybe, but in radiation and not in anesthesia or intensive care. So we have to involve them in helping us if there was any problem. And therefore it's good to have medical simulation and in situ simulation. Regarding the fasting, we all know that our children have to have empty stomachs, but classically we say it's 6 hours before the anesthesia and 2 hours for clear liquids. Some studies showed that 4 hours would be enough, but in the case of radiation therapy, where you have, well, especially in neurological patients, where you have the crossroad reflexes that are often quite bad, is this sensible? Is this acceptable? Questions to be asked. Also, we have to ask ourselves, do we accept clinically unstable patients? Because usually for a surgery, if minor surgery, if a baby has a bronchiolitis, for instance, we will not put him asleep because the risk would be too important. But in a oncological context, we need this treatment to give him the best chances for being healthy again. And should we say, okay, today we will not put him asleep, or should we just go on, take the risk? So also we need to avoid iatrogenic complications. And this is our challenge and our responsibility. We should not lose precious time. And as always in an operational theater, the surgeon is waiting for you to finish your anesthesia, maybe your local anesthesia, and he's kind of nervous. And so you get nervous too. Well, in the radiation center, it's a bit the same. You have to be time efficient because there's a long list of other patients that are waiting. So there's maybe the best possible technique to be as efficient as possible, especially if you want also the child to wake up early and be able to live a normal life afterwards. Also the means, the infrastructures. So that's a big issue. Very often in radiation centers, we don't have a recovery room. We don't have a gas scavenging system. So this is very political and very administrative, and we have to sensitize these people that what we do is very important, and that safety for patients is very important. So regarding the complications, we know that in ASA 1 patients, only pediatric patients that have no problems, but for just one anesthesia, these risks would be of 0.4 out of 1,000, according to one publication. But this can be higher, 5.2 in another observational trial. So it's quite big, and we know that many anesthesiologists who deal with adults are not very happy with children because it stresses them quite a bit. Also, on long term, we want to know if there might be neurological risks for immature brains, like in children. Then we know that there is a neurotoxicity and an impact on the synaptogenesis, especially during the growth spurt period. Also, there might be, well, cellular death. So what that might happen if you do one anesthesia. What does it also happen when you do 30 anesthesias every day? So is there some evidence? And you look at the literature and you see that there's, well, not really, we don't really know. And this is what is so interesting, because we can maybe discuss about this a little more, we can publish more, and we can do more research about this and to understand what is really going on. So these are the controversies in iterative anesthesia, invasive versus minimal handling. Should we do sedation or general anesthesia? Should we do a general anesthesia intravenously or through inhalation? And what is the management of the airways? And also the question, do we need an intravenous line every time? Or maybe we can make some exceptions, even though it does not really correspond to the 10 commandments I was talking to you before. So that's why 3 years ago, I welcomed a lot of colleagues from all over the world in this first international meeting on iterative pediatric anesthesia here in Nice. And it was a very nice meeting, very interesting. And we wanted to see each other again and talk again. But then COVID came, and since then there's a kind of a rest. But perhaps maybe something more will happen in the next future. And maybe I was thinking that if I was invited in Istanbul in next October, some of you colleagues and us and me, we can come together and sit together and discuss all this together and these issues. That would be very interesting for me to meet you and to discuss that. So as a conclusion, I would say that radiation anesthesiologists need legitimation from their own professional congregation. Some used protocols might not correspond to the dogma which we have to these commandments. They are off-label, but they need to be considered, and they should be acknowledged as an indispensable support for the well-being of the child undergoing radiation therapy. So we need standards, infrastructures, and minimal handling, and this could be defined by guidelines. So multidisciplinary discussions are definitely a plus. And this is the child we treated at the beginning, who actually, after a few weeks, got better and better. And this is how he put himself asleep by himself. As you can see, he's watching, well, you don't see it, but because the screen is here, but he's watching TV, well, a film while putting himself asleep. So that's very interesting and nice experience. So again, if you want to communicate also before maybe meeting in Istanbul, then this is my address with which you can contact me. So this is the end of my presentation, and I thank you very much for your attention.
Okay, this is the last lecture. I'd like to introduce the third speaker, Dr. Jason Earl Doctor. His lecture title is Post-Operative Management of Children After Major Tumor Excision Surgery. He is professor and consultant anesthesiologist, Department of Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, Homi Bhabha National Institute, Mumbai, India. He is editorial board member in Indian Journal of Anesthesia, and he is a reviewer for Indian Journal of Anesthesia, JOACP, ARA, and IJMS. And his interests are management of difficult airway, pediatric anesthesiology, postgraduate teacher, guideline commitment member for drafting AIDAA airway guidelines for 2016, and AIDAA National EC member, and also West Zone member. Dr. Jason, please.
So good afternoon, everyone. I will be talking about post-operative management of children after major tumor excision surgery. So before I begin my talk, I would like to take a poll question as to who manages the post-operative pain in your institute in children undergoing tumor resection surgery. A, pediatrician, B, surgeon, C, anesthesiologist, D, dedicated acute pain service, including anesthesia run APS. So we give you 30 seconds to complete the poll. And we can have the responses, Vivian, in whenever you are ready. Right. So I begin with the next bit of my talk, that what are the components of post-operative management that I will be addressing. So I will be covering the post-operative analgesia and pain management, the post-operative monitoring, post-operative ventilation, post-operative delirium in children, what are the post-operative investigations that are routinely required, the fluid management and resumption of enteral feeding, mobilization and care of lines. Coming to the first component, that is the post-operative analgesia. So usually we put a 19 gauge or 18 gauge epidural catheters in the thoracic, lumbar or caudal segments, and they are usually inserted according to the need of the surgery and congruent to the site of surgical incision. This picture describes, shows you the various components of an epidural set with an epidural needle, a loss of resistance syringe, a catheter, a filter, and a guide, right? So coming to the post-operative, once the epidural is inserted and the post-operative pain management needs to be taken care of, we need to check the epidural band, anesthetic band. So in older children, similar to adults, we can give smaller volumes of local anesthetic, 2 to 3 ml, okay, and check the band, and they will reply to the questions. In infants or extremely small children, an ice test can be tried when the infant is sleeping. So at the site of the surgical incision, which is the blocked dermatome, we put an ice cube at our institute and gradually move to the site of the unblocked area. So no response at the operative site versus movement of the child at the normal site is highly suggestive of a working epidural. However, this is and should be interpreted with caution. Gentle palpation of the surgical site can also be done, and this should not, however, be repeated at every visit. So these are some of the techniques that we often use to check the adequacy of the anesthetic band. Now, what is the protocol if the anesthetic band, if there is inadequate pain relief with an ongoing epidural analgesia? We can either give an epidural and additional bolus to block additional 3 to 4 dermatomes. Additional boluses, the nature will depend on the rate of the ongoing infusion and permissible volume so that we do not exceed the toxic dose. If the basal infusion does not permit an additional bolus, 0.5 or 1 be used instead of levobupivacaine. And if we go up on the volume of basal infusion, then we need to reduce the concentration or dilute it further so that we do not exceed the toxic dose. If, however, the epidural catheter has a band which is not congruent to the surgical site and the epidural catheter is threaded more than 3 to 5 centimeters in the epidural space, consider withdrawing the catheter only after confirming the coagulation profile and when there is no major blood loss that has been that has occurred in the intraoperative period. So what are the doses of the epidural local anesthetic? For continuous epidural infusion, we use a bupivacaine dose of 0.2 milligram per kilo per hour in children who are less than 4 months. Between 4 and 18 months, we use a dose of 0.25 milligram per kilo per hour. And more than 18 months, we advocate a dose of 0.3 to 0.375 milligram per kilo per hour. If a higher volume rate is required, concentration has to be reduced to ensure that maximum dose of local anesthetic has not been exceeded. The preferred concentration of local anesthetic is 0.05 to 0.1% levobupivacaine, and epidural test doses and bolus doses of infusions or local anesthetics are usually avoided in children who are on mechanical ventilation and with hemodynamic instability who are on vasopressors. In these children, we often advocate sedation and opioid infusions so that the pain relief can be taken care of. However, the epidural can be restarted when we are planning weaning from the ventilator. Epidural additives, the most common epidural additives are opioids. So in children who are less than 6 months of age, we usually avoid opioids, and fentanyl is the preferred opioid at our institute. Between 6 months to 12 years, we can give 1 microgram per ml of local anesthetic. And in children who are more than 12 years of age, fentanyl 2 microgram per ml with the local anesthetic can be added as an epidural additive. We use elastomeric pumps with multi-rate balloon pumps. Okay, the infusion can be adjusted to 2, 3, and 5 ml depending on the weight of the child, the domatomes to be covered, and the dose requirement. So there is a variable rate infuser here and a balloon elastomeric pump, and you can change the rate of infusion by using the key and changing the rate. Again, how do you measure pain scores in children? It's extremely challenging. There are various scores described, with the two important ones being the FLEX scale, which is the face, legs, activity, cry, and consolability, with the maximum score being 10 and the minimum score being 0. Okay, so it is preferable to get the score as low as possible. And self-reported pain scales can be used in older children. Apart from this, the Wong-Baker scale, which has this faces scale, with 10 showing as maximum hertz maximum and 0 showing as no hurt. Usually children comprehend to these facial expressions very well, and they can tell you what is the amount of pain that they are currently having. So coming to the next component, if the epidurals are contraindicated or central neuraxial blockade has some problems, then we can often use truncal catheters or regional catheters, which has been very popular in the recent past and are getting increasingly popular, with rectus sheath, transversus abdominis plane catheters, quadratus lumborum, erector spinae, paravertebral. These are all the other truncal blocks that have been described in literature and are practiced at various institutes. Coming to the parent or nurse controlled analgesia techniques. So in children whom we cannot give regionals or we cannot get central neuraxial blockade, we often prefer a CAD legacy PCA pump, which could be parent controlled or nurse controlled analgesia, and we usually use fentanyl in these pumps. After controlling the baseline pain by giving 1 microgram per kilo to reduce the baseline pain scores, parents should be counseled about the side effect profile of the opioid use. And we do not use a basal infusion. We use a demand dose with 0.5 microgram per kilo with a lockout interval of 20 minutes with this PCA pump. So this is a parent or a nurse controlled analgesia technique. Apart from this, various co-analgesics like intravenous paracetamol, depending on the weight of the child, the dose can be adjusted and the interval needs to be taken care of with intravenous paracetamol. Also, oral route also can be used with if it is not a contraindication. So less than 3 months and more than 3 months, depending on the age of the child, 10 milligram per kilo or 15 milligram per kilo every 8 hourly or 6 to 8 hourly can be advocated. Apart from this, NSAIDs like ibuprofen, which has been licensed from 3 months of age. So between 3 and 6 months, 5 milligram per kilo, and more than 6 months, 10 milligram per kilo every 8 hourly is usually advocated. Diclofenac can be given 1 milligram per kilo in children more than 6 months to a year, with a maximum dose of 3 milligram per kilo per day. Whenever we are using NSAIDs, it is preferable to use this for a short duration of 1 to 3 days. Ibuprofen has the least side effect profile, and if you need to use it for a longer time, then co-prescription of a PPI is advised. Coming to the second bit, that is the post-operative monitoring. Apart from the routine monitoring of cardiovascular system, respiratory system with ECG, NIBP, pulse oximetry, temperature, alertness, pain score, urine output, sugars, temperature of peripheries and capillary refill time, some specific monitoring like invasive blood pressure monitoring, arterial blood gas showing oxygenation, ventilation, and acid-base status, central venous pressure, arterial lactate, perfusion status, transthoracic echo showing the IVC diameter and perfusion status can also be used. Point of care coagulation testing like thromboelastography can be used in children who've had a major blood loss, intraoperative blood loss. Apart from that, ventilatory parameters, input-output charting, abdominal girth, bowel movement, Ryle's tube aspirate and nasogastric tube aspirate, incidence of post-operative nausea, vomiting, movement of the chest tube, drains, surgical drains and wound site can also be inspected, and this will give you a lot of other additional information. Coming to the third component, that is a post-operative mechanical ventilation. The indications of post-operative mechanical ventilation are a child with hypothermia, massive blood loss with dyselectrolytemia, coagulopathy needing correction, extensive surgical resection with retroperitoneal dissection, bowel handling, and a surge response, hemodynamic instability, inadequate respiratory attempts or patient being sedated and unable to maintain spontaneous breathing are some of the indications where children need to go on post-operative mechanical ventilation. We try and get children extubated as early as possible and as soon as they are alert, warm, comfortable, pain-free, and hemodynamically stable. Coming to the post-operative delirium, so Lewis and colleagues reported an incidence of 18% of emergence agitation and emergence delirium, which is synonymous, in children between 3 to 7 years of age, and it usually lasts between 14 minutes but may go on up to 45 minutes. It is described as a dissociated state of consciousness after anesthesia and is characterized by crying, thrashing, kicking, uncooperative behavior, inconsolability, incoherence, unresponsiveness, irritability, and psychomotor agitation. So these are some of the characteristics that are used to describe post-operative delirium. This is a very good article, which is a review article published in the British Journal of Anesthesia in 2017, giving a brief overview of the pediatric emergence delirium, and it gives a comprehensive review and interpretation of literature. So what are the proposed contributors to emergence delirium? Use of volatile anesthetics, certain types of surgery like ENT surgery and head neck surgery, patient age between 3 to 7 years of age, increased parental and patient anxiety, patient pre-existing behavior, and patient and parent interaction with healthcare providers are some of the components and contributors to development of emergence delirium. There's a PED score that has been described, which has 5 criteria, and each criteria has 5 points. So maximum achievable score is 20. A score of more than or equal to 10 has 64% sensitivity and 86% specificity for the diagnosis of emergence delirium. And a score of more than or equal to 12 has 100% sensitivity and 94.5% specificity for the diagnosis of emergence delirium. The components are of this score are eye contact, purposeful movement, awareness of surroundings, restlessness, inconsolability, and they are scored based on this score. This is widely available on the internet as a scoring system. So what are the strategies to decrease the incidence of emergence delirium? Behavior management, using TIVA more than volatile anesthetics, gradually reducing the dosage of volatile anesthetics, acupuncture, regional anesthesia with adequate pain control, and certain medications like alpha-2 agonists, melatonin, gabapentin are known to decrease the incidence of emergence delirium. Coming to the post-operative investigations, a CBC and a coagulation profile with TEG for massive blood transfusion with coagulopathy is warranted. Arterial blood gas with electrolytes, that is sodium, potassium, chloride, calcium, magnesium, can be done. RFTs, LFTs, depending on the blood loss and the surgery performed. Sugars need to be monitored. Any other investigations based on the surgery that has been done. Post-operative fluid therapy and enteral feeding. So enteral feeding or oral feeding has to resume as soon as the child is fully awake and it is surgically feasible. Maintenance IV fluids in the post-operative period should be of isotonic solutions with appropriate volume of potassium chloride and dextrose, as they significantly decrease the risk of developing hyponatremia and hypoglycemia. IV fluids should be given only till the child is NBM, preferably with 1% DRL to avoid protein catabolism and avoid hypoglycemia. So what is the importance of 1% or 2% DRL? Because of the dextrose, it avoids hypoglycemia and the problems of starvation ketosis. And avoiding excessive amount of dextrose avoids hyperglycemia and osmotic diuresis with dyselectrolytemia. So isotonic solution is preferred because the hyponatremia incidence is lower, and increased ADH in the perioperative period causes an increased incidence of fluid retention in children. So that is why isotonic fluid will help avoid this development of dyselectrolytemia and hyponatremia. The other general measures in pediatrics are parental presence is very calming to the child. Usually toys, videos, and distraction techniques are also advocated. IV access should be splinted so that they don't come out and you don't have a thrashing child with no IV access. Faster mobilization with adequate pain relief, warm environment, adequate forced air warming, maintenance of ambient temperature, early removal of lines, tubes, Riles tubes, Foley's catheters, and drains are essential. Dressing of lines like PICC and central line are necessary for long-term use to avoid infection. So there are a lot of articles on the internet which show this enhanced recovery program in pediatrics. It is an upcoming trend. And in the post-operative, it has three components: preoperative, intraoperative, and post-operative. The post-operative components, which we've covered, like minimization of drains, duration, early mobilization, occupational therapy, early use, early oral and enteral nutrition, diet progression, and scheduled multimodal analgesics are some of the components that we have already discussed in our talk. So coming to the procedure-specific post-operative management, there are three different surgeries that I will be covering, which are essential in the post-operative management. So neuroblastoma is one of them, which has been covered by Dr. Bohr in the earlier lectures. So major blood loss may lead to hypotension, coagulopathy, acute renal failure, ischemic bowel, and needs to be addressed in an intensive care setting. Management of intravascular fluid status, vasopressors, and hemodynamics is important for the first 24 to 48 hours, as some of them are known to have a turbulent perioperative course. Again, coming to Wilms tumor, major blood loss, hemodynamic instability, coagulopathy for large tumors and major resections is important. Urine output needs to be monitored and renal failure needs to be looked for, especially in case of bilateral tumors. There may be a requirement for dialysis and patients may become dialysis dependent. Hyperkalemia should also be watched for. Tumor thrombus with embolization into the pulmonary circulation and pulmonary embolism needs to be watched for. Hypertension, renin levels may fall post-resection in renin-secreting tumors, but blood pressure may take a month to normalize. So antihypertensives can be discontinued approximately after 1 to 3 weeks post-surgery because the patient's blood pressure may remain high for a couple of days post-surgery. Coming to the last bit, that liver resections, post-operatively, in major liver resections with blood loss, coagulation parameters, TEG, hemodynamics, urine output needs to be monitored. Sugars and liver profiles need to be ruled to be monitored to rule out liver failure. Again, monitor for post-operative liver dysfunction, bleeding, coagulation abnormalities, renal dysfunction, and give adequate coverage with antibiotics due to increased incidence of sepsis and infections. Thank you for patient listening. I'll be happy to take questions. Thank you.
Okay, thank you for your informative lecture. Okay, Dr. Sapil.
Hi. Thank you for our speakers and moderators. It has been a very informative webinar, and we have many questions. We can start with, I think there was a question regarding the guidelines to initiate fluid therapy after the removal of the tumor during surgery. I think Dr. Canan may answer this. How do you manage and the fluid therapy after the tumor has been resected or taken out, the vasodilation?
Hi, thank you for giving me this question. First of all, we give crystalloid solutions, but if you give too much crystalloid solutions, like a 30, 50 ml per kilogram, then you may use a colloid also. You may use 5% albumin or hydroxyethyl starch, and you can give bolus doses, but avoid to give too much, because we know after that we might have pulmonary edema. That's why always take a control. If you use remifentanil or esmolol before whatever you use, just stop that. And also you should follow the surgeon, how he managed the tumor. And before he clamp the tumor, clamp the tumor from the before ligation, you should be ready to close, to turn it off all the remifentanil or whatever you use, esmolol or others, and give the fluid, and always be prepared for the hypertension, and keep ready all the norepinephrine, sometimes epinephrine. But in my experience, we got too many neuroblastoma till that time. I can say last 2 years also we have nearly 50. And since 2000, we have 280 neuroblastoma patients. I can say just 2 or 3 of them had hypertension, not more than much. Yeah.
Thank you, Dr. Canan. And again, I'm continuing with you that there is another question regarding the sodium nitroprusside usage in pediatric patients. Do we use it, or
We don't.
Any precautions that we when we use it? Your comments, please.
Yeah, sodium nitroprusside is really very potent agent, and you have to be very careful. Also, if you go up to a high dose of level, then you can see toxicity too, and you can see carboxyhemoglobin rise up, and hypertension goes very deeply. So it's therapy is very sensitive. I don't prefer to use for children, but in the literature you can see if you don't have any other agent, maybe you can use very precautiously.
Thank you. And we had another question regarding the dose of tranexamic acid during the operation. When do you begin, which dose, and how long do you continue to use it?
Yeah, in the beginning, while surgeon goes to incision, that time we start. If we, always we check the tumor before, how big it is, how the close relationship to others, all veins and arteria. That's why we see the tumor is going to bleed. That's why we give in the beginning of the operation 15 per kilograms. But if the patients keep bleeding, then we might use infusion also. Infusion doses is 5 to 10 milligram per kilogram hour. So you can use infusion, but we don't need that much. Sometimes if we see it's bleeding, we give another boluses also, but then we don't need others.
Does any other of our speakers have any comments on these questions? You can also make contributions. And the one more question is about TIVA in neuroblastoma during surgery. Are there strong evidences that saying that use TIVA or use inhalation?
No, in children, we don't have any studies on that. It's really tough to do. studies in children also. But we know many studies on the animal studies and some of the adult studies, even retrospective studies. We can say don't use volatile agents. But some of the data we know, it might have negative effect on it. So if we have a choice, why don't we use TIVA? We can use propofol and we know the propofol has many good effects also on the postoperative vomiting and nausea and delirium, etc. So we can use it.
Thank you, Dr. Canan.
May I make a comment?
Yes, of course.
Yes, just about this surgery. I think what is so important as monitoring is not so much our machines, but it's communication. And it is the communication between us and the surgeon, or between the surgeon and us, that he anticipates, that he tells us what is happening, what he's doing. We look at the field, at the operation field, and see how he's doing, if he's having difficulties with some venous or artery, and the communication is the best monitoring of a safe surgery, I would say.
You're right.
And also for Dr. Jason, do you use gabapentin or pregabalin, or when do you begin if you expect too much pain after postoperative pain in those children in order to prevent chronic pain, or your experience about this?
Correct. So the issue is if you're managing the acute pain in the perioperative period, usually the incidence of that progressing to chronic pain is a relatively rare thing in children, but it's not unknown. So you can take it immediately post-operatively. We do not advocate starting gabapentin or pregabalin at our institute unless it's a thoracotomy or a high risk for neuropathic pain in the post-operative period. So in the initial 3 or 4 days, we have a dedicated acute pain service and who goes on regularly monitoring these patients for at least a couple of days in the post-operative period. And then we have a chronic pain OPD. So if the pain persists or if it continues beyond 4 or 5 days and cannot be explained by the perioperative period, you find out what is the nature and the cause for the pain. And if it satisfies the pain detect criteria for any of the neuropathic or progression to chronic pain, then definitely we refer to the chronic pain OPD, and or if the patient is admitted in the ward, we do start them on gabapentin, maybe 10 milligram per kilo, or depending on the age and weight of the child. And if that is a risk for developing chronic pain, definitely it's justified in starting. So pregabalin, we don't advocate because it's a ready capsule. We don't have formulations which can change the concentration, but fortunately for gabapentin, we have a syrup which is available. So you can titrate the dose depending on the weight of the child. So gabapentin is definitely preferred versus pregabalin. Only in indicated cases.
Thank you, Dr. Jason. Dr. Hisu, Kim, do you want to ask the questions to our speakers?
Okay. Dr. Bo, okay, there is a problem for the transfusion, right? Okay, do you have any idea for the transfusion guideline for those children?
And for the neuroblastoma, there is no specific guidelines for neuroblastoma, but for the tumor child, restrictive approach should be used. And for the guideline says till 7 and 8 grams per deciliter is enough. But if the patient is in newborn, and if it's on the mechanical ventilation, you may rise up to 12. But you should manage the oxygenation and hemodynamically stabilization. For the infant, 7 grams is enough.
Okay, thank you for your answer. I have one question to Lucas, Dr. Lucas. Okay. Do you have any idea for using PICC for those children? Peripherally inserted central catheter, right?
Yes. Yes. Well, there was also the question of an attendant asking if the total intravenous anesthesia was the right standard. And before answering actually this question, because I would say, yes, of course, it is a very good way of handling these patients, but still the question you have to ask yourself is, what are your means? And this is one of the key questions. Do we have in central access, or if we don't, what kind of other alternatives would we have? And it's interesting because there have been different surveys on which I participated to understand what the usual standards would be, the usual protocols would be in radiation centers, and actually 60 to 70% would answer that TIVA would be what they use. The inhalation anesthesia would be an alternative to it, because in this case we would be less dependent on central catheters. And so it's interesting to understand the right balance between how invasive we should be, also according to what kind of means we have. I think a second question on this behalf is more important than venous access would be what kind of airway management would we do in iterative anesthesia? And I don't want to anticipate in a certain way, because I said I would not give you recipes, but I think laryngeal mask is really something extremely useful. And I've been during these 6 years, I've been performing this anesthesia in proton therapy center. I was very happy that somebody invented 25 years ago this device, because it's very useful.
Thank you.
Yeah, thank you. May I have one question to Dr. Lucas? Could you share your experience about TIVA in pediatric, especially in radiation therapy? Yes.
Yes. Well, to tell you the truth, we do any kind of protocol. We have both inhalation as also TIVA. With TIVA, what we would do is rather doing the induction in a special room. We use usually propofol, or it might be also sometimes we use the sedation with the dexmedetomidine intravenously. But let's say the depth of anesthesia will be more, let's say, less clearly shown unless we do a very deep anesthesia right from the beginning. And in this case, we have to adapt to the patient, and every patient is different. We see many big differences in the posology, in the need of what kind of quantity we want to inject according to the patient. So we don't have standard. But what I usually do is give a heavy dosage, which would be much more than the classical 4 milligrams kilo as the induction, and then adapt myself according to the response of the child. Most of the time we would use inhalation therapy treatment anesthesia, because it gives us much more, we can foresee much better what is going to happen. Because with TIVA, if we don't have the right dosage, the child might be too superficial, and then the child will be moving, and again you lose 10 minutes, 15 minutes according, or the child might be coughing. And then if during the treatment, during the radiation, the child is coughing, it's not such a nice thing. Or it would be too deep, and if you don't have laryngeal mask, the child will go in apnea and will not breathe, and then it's again catastrophe, and you have to rush into the treatment room. So inhalation is, I think, a very good alternative, because it really tells you the depth of the child. Also, inhalation gives you the opportunity to have a very, very fast recovery. But sometimes, and that week I can tell you, we saw children who had with inhalation so fast recoveries. Therefore, it's very important to have a very quiet environment, because if it's too fast, this delirium we were talking about before, is something that we could experience, not very often, but let's say in 5% of our cases. And this is very, very unpleasant. And therefore, sometimes you need some more drugs, like for instance, what we do when the child is asleep, we give intranasal midazolam just to allow the child to wake up slowly and calmer, and to have a physiological sleep before getting up. So there are many different kind of techniques, and I think it's really very interesting to discuss them.
Yeah, thank you. Yes, one more question to Dr. Jason. Could you explain a bit about multimodal analgesia strategy, and how can we educate to the nurse to provide that? Yes.
Correct. So when we have patients who are post-operative immediate for major resection surgeries like hepatoblastoma or a neuroblastoma or a Wilms tumor, with an epidural infusion in place, till we document a working epidural and anesthetic band, we usually prefer to keep these children in the recovery room. Once we have a documented anesthetic band, once we take care of the baseline pain, we start them on an elastomeric pump, which I described in my talk. And depending on the concentration and the volume that we infuse through the epidural catheter, we consider shifting them on the floor to the ward. We have a dedicated acute pain service team which visits these patients, pediatric as well as adult. We have a database for every day. Whoever is due for an epidural removal, or whoever is not comfortable on a working epidural, whoever needs an additional dose. So we have a pain list, and we visit these patients on the floor, and we try and augment the analgesic effect by giving them either a parent-controlled or a nurse-controlled analgesia, or co-analgesics, either by the intravenous route with fentanyl or opioids or paracetamol. And if they are on orals, we definitely consider ibugesic, ibuprofen, and paracetamol syrup combinations. So this is how, with multimodal strategy, we try and optimize the pain relief of these children. And there is a pain sister in the ward who, along with the hemodynamics charting, they usually chart the pain as the fifth vital sign. So there's a dedicated nursing team in the pediatric ward who takes care of and who is aware of how to assess pain in these children. So whenever they feel that the pain relief is not adequate, they usually call on the dedicated mobile number that we have for the pain service. And the pain team goes and visits them and sorts out all these pain issues. If we are not comfortable with this child in the ward, or he or she requires a lot of opioids or analgesics, we usually try and avoid these things on the floor. We try and shift them back to the recovery room, optimize the pain relief, and make sure that they go back, because we don't want to give opioids or any additional boluses in an unsupervised environment. So that's a word of caution there, that no baseline infusions of opioids, and nothing which is unsafe in the ward for sure. If you want to give any of this, you're free to do so, but after shifting the patient to the recovery room. Right? So that's an important message there.
Yes, thank you.
Okay, I have a question for the PONV problems. But do you have any suggestions for the prevention of PONV for the children? Dr. Kenneborough?
Yeah. PONV problem, luckily we don't see much, because neuroblastoma patients are infants, mainly, under 4 years old, we see. And under 3 years old, we don't see too much PONV. But if the patient gives the history about former operation, she had too much vomiting and nausea, and if the parent says she has motion sickness, then you may give medication. at the end of the operation. You can give ondansetron 0.15 milligram per kilogram. And so you can keep the patient without vomiting and nausea. And the dexmedetomidine, they don't suggest to use because of dexmedetomidine might suppress the immunosuppression, even though even single dose suppression didn't show, but just might have. And also some studies about the dexamethasone has tumor lesions can make a tumor lesions. That's why they don't suggest using dexmedetomidine. Dexamethasone.
Okay, thank you. Thank you for your suggestion. So you mean the dexamethasone rather than dexmedetomidine, right?
Yes, yes.
Okay.
Dexamethasone. Dexmedetomidine, I like dexamethasone.
Okay,
The
great.
dexmedetomidine, sorry. Dexmedetomidine, especially for the delirium, it's really nice drug.
Okay.
At the end of the surgery, we give dexmedetomidine, just 0.5 microgram per kilogram, and as a 5 minutes bolus. And after that, waking up child, and if you use, you will see the difference. And we don't see too much delirium if we use dexmedetomidine. Also for the premedication, it's good, but if the operation time is too short because of the dexmedetomidine effect is long, I suggest you shouldn't use just the small procedures. But the big procedures, big operations, you can use for premedication also, intranasally, and also it's easy to tolerate for children. And as you know, midazolam taste is really bitter. I don't know, did you taste it? It's sometimes I'm very sorry for the child, even though we put it in a in juice, it's not easy to swallow it. But dexmedetomidine, it's intranasally, didn't hurt them. Just, and also they get used to get nasal drops and air sometimes, so they don't refuse it like oral midazolam. We use it.
Okay, thank you. Thank you for your nice answers.
And I want to ask dexmedetomidine about a question with dexmedetomidine. Dr. Lucas, do you use it during radiotherapy premedications for a child coming every day as a premedication? I think it can be used, but I couldn't find any studies about that.
Yes, there are no studies about this, but we used it actually sometimes in very specific patients that had very difficult waking ups. So we use it once the induction was done, so there was no aggressive behavior from our side, and we would just give it intranasally, up to 1 microgram per kilo. And so that waking up would be very, very smooth, and this delirium we were talking about would not happen. The thing is that it takes a long time, and that means that the child will stay in our recovery room for, well, quite a long time, up to 1 hour or more, which on a daily basis is okay, but it depends on the parents also. Some children and some parents, just once they did their anesthesia, they just want to go away. Others will stay and they will play with their friends because there are other children around and we have a playground. And so it depends very much on the patient. The post-anesthesia period, I think, is getting much nicer if you give these children to drink or to eat right away. And it becomes a kind of routine, a ritual. And so many of our children, they wake up and they get the milk right away and they start sucking on the milk, and that is the best way of calming them down if ever they were kind of let's say nervous, which is actually very interesting because after having done a lot of surgery in difficult countries in Africa, and we didn't have many means, and the best analgesic even for big surgery is always the mother's breast, and this is fascinating.
I have a comment on that. Like Dr. Lucas described, that if you were giving dexmedetomidine for a daycare procedure where they're absolutely going to be coming in every day, and dexmedetomidine is not a drug which is without problems. You can have dangerous bradycardia, you can have dangerous hypotension. So if you have better drugs available, or if you can resume oral feeds as early as possible, I think that's a safer bet. And if you need to give these drugs, then they are best given in patients who are going to be monitored for a good amount of time in the post-operative recovery. That is a good take-home message, that you can't be sending them off by giving it intranasal or orally and maybe going back home within half an hour. I don't think that's the thing that we should accept.
Yes, I very much agree with this. And that's why I was speaking about the means and the infrastructures. In a radiation center, very often you don't have a recovery room, but this is something which we should have. And I'm glad that we have a very good recovery room, and we can wait, and the patients are monitored until they are really well awake. And this is something very important, because I realize this is a political will. When the administration builds up a radiation center, they very often forget about anesthesia, and this is something that we as clinicians have to emphasize about on the administration. But anyway, dexmedetomidine is something we use very rarely. Also because the length of its action is for our standards too long, and we want children to be able to go away as soon as possible after the anesthesia.
Okay. Yes, to Dr. Lucas Optic. I have do you have a scavenging system in radiation therapy unit, or as I seen in the presentation, you show the child with like a video, and you have a mask. This is inhalation plus nitrous oxide and oxygen.
We don't use N2O anymore. We don't use any. We just use anesthetic halogens like Sevoran, but no other complementary gas. But we have a scavenging system, which actually, again, we come back to the infrastructures. When I was asked to build up this center, there was nothing. And I was lucky, because administration for a short time was very compliant, and they gave me many of the devices and the infrastructures I asked for. And we could have a scavenging system. I agree, if you don't have a scavenging system, or this ALD absorber, which absorbs also the halogens, then you should not use inhalation in a radiation center. That would be really not. Then you should use only intravenous. But yes, if you have it, I think inhalation is a very good alternative to intravenous anesthesia.
Yes, thank you.
Thank you. Thank you to all our speakers and our moderators. I think there are lots of issues to discuss, since this is a very, very empty topic. I think we will be discussing these issues later on during maybe in the conferences in France or in Istanbul. Now we have to end up our webinar. It's clear that we need a team approach for education, nurses, and for the care of our cancer patients. So at the end of the webinar, I want to remind that the certificate of attendances will be automatically generated and forwarded to those who submitted the post-webinar surveys. These post-webinar surveys will be forwarded tomorrow at 5 Singapore time through emails. So please ensure that you have correctly keyed in your full names and emails so that you can get the right certificate of attendance. Please do not forget to follow us on Facebook, on YouTube, and like us and visit us at our website at ASPA20000.com. You can be a member of ASPA through that website as well. It has many advantages and it's a lifelong membership. We are continuing to our webinars, and our next webinar will be on 19th of June and will be on the pediatric airway. We have very precious speakers there, Professor Henry Tan, Dr. Nandini Dev, and Dr. Josephine Tan, also who is head of the our president of the ASPA. So stay tuned and please remember that you have to, in order to join the webinars, you have to register first. Registration is free so that you can get the next announcements. I want to remind you that we have our annual meeting of ASPA 2022 at Istanbul. It's between 14th and 16th October. Please visit the website and you can register to our meeting as well as to the workshops. They are quickly going on, and we have very few places left. Please organize your journey to Istanbul. Welcome to Istanbul on October. And we have some more announcements regarding ASPA. We have our virtual ASPA annual general meeting on 24th of July. So the registration link was sent to all ASPA members through their emails. Please check your emails and your spam boxes as well. We will be very glad to have you in that annual general meeting. And also, I want to remind that ASPA is an empowering through education society. Our mission is to foster the highest standard of pediatric anesthesia care in Asia. And the ASPA is a non-profit organization. So we seek your help to donate and help us in our cause. Please stay tuned with us and up to meeting the 3rd Sunday of June. Hope to see you there. Thank you for joining.